Fortunately, most of my slides have been presented before, so I can go quickly. These are my conflicts of interest. So my question is, should we do recruitment maneuver? Should we recruit the lung? Well, I could stop there and say we have the response. We have seen these slides several times before. This is a randomized control trial, multi-center, 1,000 patients or more, very nicely done, and which really asks the question, if we do a recruitment technique and try to optimize PEEP for high PEEP, does it help patients? The answer is no. So we should not. And there are reasons for that, and I think we hope this is the last study of this kind where we simply randomize patients to either high PEEP or low PEEP without any idea whether the patient is going to respond or what's the individual physiology of the patient. So there are many aspects of recruitment maneuvers which should tell us that we should be very careful. First, most of the effect is transient. You see here a series of patients, and there are multiple series where you see the oxygenation improving just after the recruitment maneuver, but after a few minutes the oxygenation goes down again, and only a few patients still keep the PaO2 improvement. So this effect is transient. So maybe you reopen the lung for some patients, but then the lung closes again. And there have been one randomized trial, which is often forgotten, of recruitment maneuvers versus sham maneuvers in patients who were already on high PEEP. And the ARDS-NET decided to stop recruitment maneuver because the effect was completely negative, again because of this transient effect. And if you look at the side effect, this is a beautiful study by Jean-Michel Arnal. He looked at constant recruitment maneuver at 40 centimeters of water for 30 seconds. And you see on the left the increase in lung volume, and you see that maybe most of the increase is obtained after 10 seconds. But on the right you see the effect on the blood pressure. And after 10 seconds you see a huge drop in blood pressure. So if anything, if you wanted really to do a recruitment maneuver, make it short to avoid the side effect. And the hemodynamic side effects have been described in many studies, but they may be different in responder versus non-responder, as we will discuss later, just to show the tracing of the blood pressure going down. So this is a very risky maneuver. This is the effect on the size of the left heart, so I'll skip that. What's the problem of all this approach where we try high PEEP versus low PEEP in everybody? Well, this is very nicely illustrated here. This is an assessment of the lung recruitability by a very complex technique, which is CT scan at 2 levels of pressure, comparing 5 to 45 centimeters of water, and measuring from lung densities how much of the lung which is completely dense is reopened at 45. So it says that some patients reopen 35 to 40, 40 to 45, or even 55 to 60% of the lung when going from 5 to 45. This is a very recruitable lung. But some patients, and maybe many patients, have 0 to 5%. They do not reopen the lung. You go from 5 to 45, they do not reopen. So why would we randomize this patient to a high PEEP and recruitment maneuver where their lung will not be reopened at least up to 45? So this is the key question today. How are we going to determine at the bedside that the patient is recruitable or not and may potentially benefit from a lung open recruitment approach? This is fascinating. We've seen this data before. This is the data from the LOVES and EXPRESS trial. And just look at the right side here. This is a change in PF ratio for patients who were enrolled into randomized controlled trials of high PEEP versus low PEEP. And of course, patients were randomized to have a higher PEEP than their clinical PEEP, or sometimes a lower PEEP. And you see the change in PEEP, the change in PEEP here. So many patients were randomized to a higher PEEP, some to a lower PEEP. This is the effect on oxygenation, the delta PF. Randomized trial, this is the first ABG after randomizing the patient. So yes, there is a significant effect of PEEP on oxygenation, but look at this data. It's all over the place. And we continue to believe that, well, yes, PEEP and oxygenation, it's an automatic effect. No, please assess what's the response of your patient to a PEEP trial, at least 2 PEEP levels, and do ABG without changing anything else. I love the approach proposed by Bob Kasmarek of the incremental PEEP trials, which take 25 minutes. In the real life, nobody's doing that. We even don't do a proper PEEP test. And this is important because this is a post-hoc analysis, but what Johan Gölliger found was that patients who increase their PF ratio, so those submitted to the high PEEP, right? Those who increase their PF ratio had a better survival. So it's a post-hoc analysis, but it suggests that if a patient does not respond to PEEP in terms of oxygenation, it should certainly not be submitted to a high PEEP. Maybe that's what we think we do, but in real practice, I don't think we do it. Maybe we can do better, and better is to try to understand what is the recruitability of the patient. I think that the best technique today is to compare what's the change in lung volume observed with PEEP compared to what's the predicted increase in lung volume. Let me explain that briefly. If you look at the compliance of the patient, compliance is a tricky parameter. Compliance tells you how much volume is related to a change in pressure. And if you go from a high PEEP to a low PEEP or low PEEP to a high PEEP, you can predict a change in lung volume. For instance, your compliance is 30 ml per centimeters of water. You change the pressure by 10. If you have no recruitment, you expect a change in lung volume of 300 ml. So if you compare this, in this example I took 20 ml, so you expect a minimal increase in lung volume of 200 ml. So if you can measure the change in lung volume and compare to the predicted change, well, you can differentiate patients who have just an increase in lung volume related to the distension of the already open lung versus those who recruit the lung. Let me show you an example. This is measured with direct measurements of lung volume. And we just separated the patient in 2 groups based on the median value. You can see that those we call low recruiters, this is the increase in end expiratory lung volume compared to FRC, had a minimal change in lung volume when we went from 5 to 15 of PEEP. Because these patients did not recruit, like the large group in Gattinoni study. Those patients, it's the same pressure, right? 5 to 15. And it's approximately the same compliance at baseline. That's why the compliance is very tricky. Same compliance, same pressure. The change in lung volume is much larger because for the same pressure you have reopened new areas. So that's what we need to know at the bedside. Whether we will use this direct measurement of lung volume, we will use other measurements like EIT, or even a simplified approach which I will show you. But I think this is the way to go to assess the patient before submitting the patient to any recruitment or PEEP trial. We have implemented a systematic approach of measuring respiratory mechanics in our patients with ARDS. And one of the techniques we use is a simplified recruitment technique to assess the recruitability at the bedside. Again, as I told you, we need to measure the change in lung volume and compare to the predicted change in lung volume based on compliance. So we do it in a very simple way, maybe simplistic, but at least we are trying to validate this approach. We just abruptly reduce the PEEP from 15 to 5, so with a delta PEEP of 10, and we measure the expired tidal volume within the next breath. And of course, this expired tidal volume will include the inspired volume plus the volume retained by PEEP. And when we compare this volume retained by PEEP to the predicted increase in lung volume, we come with no difference, which means the patient is completely non-recruitable, or with a significant difference, which means the patient is recruitable. And just to go very quickly because of time, this is the first series of patients. We look at what was the result after 1 year doing this systematic approach. And in fact, compared to a clinical PEEP, because we assessed oxygenation and we assessed recruitability, well, we found that there was a large group of patients in whom we did not change the PEEP, a small group of patients where we increased the PEEP, and very substantial group of patients in whom we decreased the PEEP because we found they did not respond in terms of lung recruitability or oxygenation. And interestingly, doing that, we found, and again, this is a very preliminary pilot data, but we found that the patients at the end of the day, after doing the measurement and changing the settings, had a better oxygenation. No big deal, easy to get, but with a lower pressure. Look at the driving pressure, which went down from 18 to 15. So by assessing individually the response to PEEP and the recruitability of the patient, you offer a safer ventilation to these patients and hopefully a more efficient and successful ventilation. Thank you very much.
Thank you very much, Laurent. And I think we are perfectly in time.